Okay, welcome back to part two. So now and for the next several weeks, we're going to be exploring different types of research study designs and the strengths and weaknesses of each and how you can utilize these within your systematic reviews or scoping reviews. Underneath research here, we have quantitative and qualitative. Qualitative is its own thing off to the side there. We're not going to be touching that area. You more than likely won't be including any qualitative studies within your reviews. Now I put a little asterisk there saying most likely you won't be, because maybe there are things that will be informative, but again, probably you won't be using too many. Now we're continuing on with epidemiologic research. We previously looked at basics related to prevalence and incidence and the study designs associated with those. Now we're going to be moving into exploring descriptive epi and observational epi, which fall underneath the non-experimental umbrella, and then also some potential experimental examples. Epi studies are classified as either observational or experimental, observational being another way of saying non-experimental. And here is a list of some of the different studies that we're going to be exploring today. Now, observational studies allow nature to take this course. Not this course, its course, excuse me. If you were to download the PowerPoint and have it in play mode, you'd see this guy running backwards on a treadmill. You would know that that's not going to end up well, and it doesn't. But as an epidemiologist, you don't intervene. It's not experimental. You're not doing anything but observing what's going to happen. And underneath the umbrella of observational studies, there's the descriptive and then there's the analytical. The descriptive are limited to a description of the occurrence of disease, and analytical then is looking at analyzing relationships. Now, descriptive studies often occur in analytical studies, or descriptive presentations occur in analytical studies. Sometimes there can be a descriptive study in and of itself, but most studies are analytical in nature. Shown here is a article from the Journal of Athletic Training looking at just only the descriptive presentation of injury rates based upon the time of the sports calendar, preseason, in-season, postseason. Could that be a little analytical? Yeah, it could be. But we don't get a great sense if there's a statistically significant difference just from looking at Table 1. Table 1 is just presenting those rates per 1,000 athletic exposures, or otherwise we would know that as incidence density. We would need to do some additional statistics to really analyze things to see if there was a statistically significant difference in those rates between groups. Just looking at it, you might have some assumptions, but you wouldn't want to draw conclusions without doing that next step. Here's an example of a descriptive epidemiologic study. This is a case series. It was published in the New England Journal of Medicine in 1981. It was one of the first papers that explored symptoms, these unusual presentations, a rare form of pneumonia, that ultimately was later identified or described as the disease AIDS. Descriptive studies are the first step in epidemiologic investigations. Pure descriptive studies make no attempts to analyze the links between exposure and effect. These studies may report mortality rates, injury rates, maternal death rates, things like that, and they may examine patterns by age, sex, or ethnicity. Here's a descriptive study example. We see a downward trend in maternal mortality in Sweden since the mid-18th century. There's this downward trend, but we see some blips upward. In the 1860, 1870 range, and then maybe again around 1930, 1935. You can speculate causes, but you don't know other than, oh, there was just an increase there. So why was there that increase? Future research would need to do that, to explore that. Another descriptive example, looking at USA, Australia, UK, Canada, looking at age-standardized death rates from heart disease, men 30 and over, and seeing that there was a downward trend becoming essentially similar to those experienced in Brazil. At the same time, an upward trend in those individuals in the Russian Federation. What can we attribute to this? Well, we're just seeing this trend. We're seeing this change over time. It's descriptive. We would need to do additional research to see were there public health measures that were recommended at that time, especially around the areas of smoking. Were there other factors at play? We don't know. Ecological studies, also known as correlational studies, these are useful for generating hypotheses. The units of analyses are groups of people rather than individuals. And so an example here, a study looking at the relationship between the average sales of anti-asthma drugs in different areas and the occurrence of an unusually high number of asthma-related deaths in a region. So you might think, oh, was the anti-asthma drug defective? Well, you would need to test that to control for potential confounders to exclude the possibility that other characteristics did not account for the relationship. Ecological studies can also be done by comparing populations in different places at the same time, or in a time series by comparing the same population in one place at different times. I don't know that you're going to see too many ecological studies. I don't recall last year any students having any of those within their systematic reviews or scoping reviews. Here's another one, daily time series example, looking at the deaths in France during the 2003 heat wave. There was a correlation between increasing temperatures and increasing numbers of deaths, so that we're able to see a number of excess deaths per day. Simple to conduct these types of studies, they're difficult to interpret, seldom possible to examine directly the potential explanations for the findings. Often these studies rely on data collected for other purposes. Unit of analysis is the group, so the link between exposure and effect at the individual level cannot be made. The ecological bias, this results if inappropriate conclusions are drawn on the basis of the data. Bias occurs because the association between variables at the group level does not necessarily represent the association that exists at the individual level. Here's an example, a bias-related example. We're seeing neonatal and maternal mortality when there is the absence of a skilled birth attendant. The lines represent maternal and neonatal mortality rates, and then the boxes represent the percentage of births without a skilled attendant. So you see that there are some Asian countries in Africa that don't have skilled attendants available. Well, the presence of or the lack of a presence of a attendant is only one possible explanation. Why are we saying that? Well, we see that the rates in the Eastern Mediterranean and Asian countries are higher than those in Europe, the Americas, Western Pacific, and so forth. But we also see that it's really high in Africa. So the lack of the skilled birth attendant is one possible explanation, but it's not the main cause or the only cause, because we see lower rates in some of the Asian countries versus Africa. Cross-sectional studies, we talked about those in the last lecture. We gave this example about cross-sectional one point in time and then serial or longitudinal cross-sectional types of studies. We also highlighted, I won't read through these again, the strengths and weaknesses of the prevalence studies. Now, let's talk about case control studies. I highlighted this in one of the discussion posts. Case control studies are really valuable because if you think about a prospective cohort study, you have people that don't have the outcome of interest, the disease or the injury at baseline, and you follow them forward in time. Well, take adhesive capsulitis, for example. How would you know how many people you needed to collect and then observe over time? Most of the time, this disease occurs between individuals between the age of 40 and 60. So would you start following, I don't know, 200,000 men and women? Probably need more women than men. It seems to maybe occur more often in women than men. Do you try to really emphasize maybe individuals that have diabetes or other endocrine disorders? Do you really kind of expand that? Now you need 400,000, 600,000. Or can you just take a group of people with adhesive capsulitis and compare them to people that don't have adhesive capsulitis and look backwards to see what risk factors potentially are associated with adhesive capsulitis? So these provide a relatively cheap way to investigate causes of disease or injury. These studies include people with the disease of interest and a control population who do not have it. This type of study compares the occurrence and the possible cause in cases and controls. Researchers collect data on the disease, like adhesive capsulitis, at one point in time, and then exposures at a previous point in time. So it's important to be able to identify your cases and then your controls. Controls, again, are people without the disease but are similar. So, for example, if you had a disease that was common only in women, your controls should not include men. They should include only women, but they should be women who do not have the disease. The most difficult task is to select controls so as to sample the exposure prevalence in the population that generated the cases. So here are the people with the cases, here are the people with controls, and then we go back and we ask about potential exposures. That gives us proportions in each group, and we're able to see if people are at greater risk or if they have a greater odds based upon their history. Some examples: researchers in Papua New Guinea compared the history of meat consumption in people who had, and I'll probably pronounce this incorrectly, Enteritis necroticans, that's the tongue twister part there for me, with people who did not have the disease. Proportionately more people who have the disease reported prior meat consumption than those who were not affected. So how did they find this info out? They interviewed subjects. Another classic example is looking at thalidomide in babies who developed limb defects. If you thought thalidomide was the problem, you would not give thalidomide to new mothers and see if it actually confirmed that limb defects occurred. That would be horribly ethically wrong. What you do instead is you look at the mothers whose babies had malformation and you compare them to mothers who did not have babies with malformation. And what they found here is of 46 mothers who had malformation, 41 had been given thalidomide during weeks 4 and 9 of their pregnancy. None of the 300 mothers in the control group had taken the drug. Incidence studies, these are the top way of doing things when you can do them. So prospective studies, we talked about them before. They are major undertakings and they can require a lot of time. So for example, what would it take to study the onset of leukemia after exposure to radiation? So if an event occurred, like a Chernobyl type event, how much time would you have to follow people for? And how much money would it take, how much resources to monitor these individuals, right? So you can see how that can be potentially challenging. So some situations, it's better to do case control than it is to do cohort. Cohort studies, again, people without the disease here at baseline, we then categorize them into those who have the exposure or who are not exposed. I like to think about it as being at risk and being at lesser risk, and then you're looking for proportions in each group. Here's that breakdown again. In the present, people without the disease, and in the future, we're looking at the proportions. Here was one of my studies, 106 Division III female athletes who started the season without injury. The at-risk group or the exposed group were people that had 4 below average scores on different tests of strength and agility. The other group was everybody else. They could have had all above average scores, or they could have had 3 or fewer scores that were below average, but not all 4. Having all 4, there was 5 out of 14 people that went on to have an injury, whereas in the other group, there was 5 out of 92. So those with all 4 scores below average were at a greater risk. Cohort studies can be conducted in one of 2 ways, either prospectively, like the Framingham study that we introduced in the prior lecture, or retrospectively. I'm jealous of people who can do retrospective studies because they have access to large medical databases, these large data sets that somebody else has already collected. Now, the Framingham study, again, prospective cohort study, information can be found in Wikipedia as well as other sources about it. Prospective cohort studies, again, are the best because you are following people from baseline. You're able to assess for all potential factors of interest and observe them over time. Retrospective, major advantages, takes less time, so you're not following people because the data has already been collected. They're less expensive to perform and much easier to perform. But the problem is, because the data has been collected already, it may be missing things of interest. Or you have to rely that maybe bias was introduced in the way things were collected, the way the data was collected. Hopefully not, but that's a potential limitation. So what does a retrospective cohort study looks like? It looks similar to a prospective. If you didn't look closely at the slide, you'd say, wait a second, that looks like a prospective cohort study. But the difference is, here in the present, we're in the present first. That's number one. We're in the present. We don't know the proportions yet. But what we do is we then go back in time. What we do have is we have a known population without the disease or injury at baseline. And then we have information that we've collected on those individuals in the past. And so we can then dichotomize them into groups and then move forward back to the present to see about proportions. So if we, for example, worked at a skilled nursing facility and in a relatively short period of time, maybe we had 70 falls out of 200 people, we would want to know why all these falls were occurring. And so if we went back and looked at those 200 individuals at baseline that they had no history of falls, we could look at what their ankle stability scores were and then come back to the present to see what the proportions were in each group. And we would see is 60% of the people with poor ankle stability had a fall, whereas only 10%. And so a risk factor here would be ankle stability. I'm not going to read through these. I'll let you do that. Important thing to highlight here is a retrospective cohort is not the same as a case control, but they have similar advantages and disadvantages. So I'm going to pause the recording, or I should say, I'll have you pause the recording. I'm going to give some dead air now. Okay, so you probably had a chance to read through those, or hopefully you had a chance. Let me know if you have any questions. As you take a look at things now, here, the investigator is helping us to understand at baseline, how the study is conducted. With a case control and with a retrospective cohort, we're looking into the past. With a prospective cohort, we're looking into the future. Same thing with a clinical trial, we're looking into the future. Here's a summary of epidemiologic studies looking at the strengths regarding different objectives. So this is just kind of reference information for you in case you come across different studies for your particular clinical question. Here's advantages and disadvantages of other observational studies. Experimental studies, these involve an active attempt to change a disease determinant, such as an exposure or a behavior, or the progress of a disease through treatment. These study designs are similar to those in other sciences: randomized controlled trials, field trials, and community trials. So our clinical trials using patients, field trials using participants that are typically healthy, and community trials using communities themselves. So with an experimental epidemiologic study, an intervention or experimentation involves attempting to change a variable in one or more groups of people. For example, elimination of dietary factor thought to cause allergy or testing a new treatment on a selected group of patients. Effects of an intervention are measured by comparing the outcome in the experimental group with that in the control group. Randomized controlled trials, an experimental study designed to look at the effects of a particular intervention using a treatment for a specific disease. Subjects in the study population are randomly allocated to intervention and control groups, and the results are assessed by comparing outcomes. I think we're familiar with these. We're going to talk about randomized controlled trials in the near future. The thing about randomized controlled trials and field trials, they look a lot alike. The way they're being differentiated here from the epidemiologic textbook that I'm resourcing is the randomized controlled trials are treating patients. The field trials are working with healthy individuals. In both cases, we can potentially calculate different rates or explore impacts upon how risk reduction might decrease. And that's where this field trial example is going to get into. We're looking at healthy people to see if an intervention helps to reduce the onset of disease or helps to reduce the risk of injury. This field trial looks just like kind of like a prospective cohort design. It also looks like a randomized controlled trial design because that's what's occurring here. There's randomization. Randomization, randomized controlled trial, you'd have one group getting the intervention, the other group not getting that intervention, or maybe a alternate intervention. And then you're looking at the onset of disease or injury in each group. So looks again like a prospective cohort, but the key feature here, randomization has occurred. Here's kind of an interesting study. Any of you female athletes, you might know that there is an increased risk of knee injury, ACL injury specifically. And what this group did is they had three groups: a group of male high school athletes, a group of female high school athletes that received no intervention, and a group of female high school athletes who received the neuromuscular reeducation program, or a program consisting of plyometrics and stretching and other activities. So they were the trained females versus the untrained females. And what they found after the course of the intervention, which I believe was 6 weeks, I'd have to go back and double check that, but they found that after participating in the program during the season, the untrained females had the greatest risk of injury. Their risk of injury was both higher than the females that were trained and the males who received no special training. And essentially, the trained females became equivalent to the males when it came to injury risk. So this was a very, very well received, clinically informative study, which really got people doing a lot of injury prevention programs for female athletes. What we see here is there was incidence density data reported in the paper. We can see this report of serious knee injury in both groups, either serious knee injury for all injuries or non-contact related injuries. Fascinating that there were no non-contact related injuries. And why is that important? Because can you reduce the risk of injury resulting from contact? That's a highly debatable question, but reducing the risk of non-contact injury, that's amazing. And then experimental epidemiology, community trials, treatment groups or communities rather than individuals. These are appropriate for diseases that are influenced by social conditions and for which prevention efforts target group behavior. If you're curious about reading about these, please go ahead and read through this here. That ends our lecture. I'm going to give about 5 seconds of dead air to allow you a chance to pause the recording and read through this to get that appreciation for community trials.